analysis by Dr. Neeja Banerjee, and it's my personal pleasure to welcome her. I'm aware personally that she's an excellent teacher, a wonderful orator, erudite, very succinct. So I'm sure you're going to enjoy this session with her. Dr. Neeja, all yours, please.
Thank you, Dr. Asha, for the kind introduction. I would like to proceed with my lecture. This is on arterial blood gas analysis. This is one investigation that US postgraduates are exposed to right from first year of your postgraduation. In fact, even during your internship days, you would see this investigation. But let's learn the stepwise analysis. One just ends up sort of forming one big diagnosis of acidosis, alkalosis without following the stepwise patterns. So I'll follow you through with the stepwise analysis of arterial blood gas. Initially, I'll tell you a little about how to do ABG sampling, what to do and what not to do, and then some background information about acid-base disorders, and we'll take you through the case scenarios of ABG interpretation. Radial artery is the commonest artery, which is used for sampling. Here is an example where the wrist is kept in an extended position and the needle is inserted at 45-degree angle. But before you puncture the artery, please remember that you have to do modified Allen's test. And this is what is done to see for adequate circulation from ulnar side. So what we do is we ask the patient to clench the fist, apply pressure on radial and ulnar both, and then release the ulnar. So once you release the ulnar pressure, there should be the hand which had become blanched earlier because of pressure of the radial and ulnar artery, that it should become suffused within 5 to 15 seconds. If it takes longer or doesn't, it stays blanched for a much longer time. That means the ulnar circulation is not adequate. Please do not puncture the radial artery of that hand. Check on the other side or use some other artery accordingly. The syringe has to be heparinized. Ideally, nowadays, pre-heparinized syringes are available. But in case if you do not have, remember to flush the syringe with 1 in 1,000 of heparin, not 1 in 5,000, because the higher the concentration of heparin, which is acidic in nature, the higher the volume, it dilutes the blood sample, and this being acidic brings about changes in the blood gases. So just take the sample, flush it, whatever stays in the coating of the syringe and in the dead space, that is good enough for heparinizing the arterial sample. These are some things which we should take into account when we are sampling. Say, suppose there is a patient whom some kind of a ventilatory change has been undertaken. Please wait for at least minimum 3 minutes. Ideal is to wait for 10 minutes for steady state to reach. In some situations like COPD, it takes even much longer for the so-called steady state to be reached. So that is the time where you wait even up to 20 to 30 minutes to take the sample. Otherwise, the expected change will not be there. And then you will unnecessarily keep on making further changes and would not be able to interpret the ABG correctly. Please always write the percentage of inspired oxygen that is being given to the patient, because PaO2 in a patient is never ever interpreted independent of the FiO2 that a patient is receiving, because it is always the PaO2 and FiO2 ratio which is to be noted whenever we are talking about hypoxia or your ARDS definitions. Everywhere it is this ratio that is talked about. So let us see a situation where a patient is getting 100% oxygen and PaO2 is also 100. If I do not know that my patient is receiving FiO2 of 1, I would think the oxygenation is very good. So this whole interpretation of ABG would be wrong. So that is why please mention the percentage of inspired air. Please mention the time. In the ABG will give you the interpretation gives you the time. Also write the condition of the patient whenever you change the ventilatory settings, because when you read the serial ABGs, that is the time you would require as to what was the condition at that time, and whenever any ventilatory change you have made, what is the condition now. Whenever you take heparin whenever you take ABG, please do not leave any air bubble inside, because what happens is this air has got oxygen and has got very little carbon dioxide. So oxygen, what is there in the air bubble is 21%. Or 760 millimeters of mercury, which is approximately 150. And in our ABG sample, the maximum would be 100. So from air bubble, oxygen would go to your ABG sample, and you'll get fallaciously high oxygen levels, right? And CO2 would diffuse from the blood to outside to this air sample. So your CO2 would be much lesser in your ABG sample. So please do not ensure that there is no air bubble. Whenever you have to transport it in cold pack with ice solution, because what happens is the metabolic process starts if it is at the room temperature. When metabolic process starts, CO2 is high, oxygen gets consumed. So again, you will not get the correct values. What are the various components of ABGs? What are the various components of ABG that are seen classically that we know of is pH, PaCO2, PaO2, bicarbonate, and base excess. But the newer machines also give you the electrolyte values, glucose, HB, and lactate, which has got a lot of importance nowadays, more so for ICU patients when you want to know the lactate levels and you want to manage your patients of sepsis according to the lactate levels accordingly. So let us see what are the normal values. The pH value is 7.35 to 7.45. Let me tell you, whenever we are doing any calculations, which I'll be teaching you further, we take consider 7.4 is the ideal. Any deviation slightly towards less than 7.4 would be slightly acidic, and towards more will be slightly alkaline, right? PaCO2 is 35 to 45 millimeters of mercury. 40 is ideal. That is the numerical value we will take. PaO2 is 80 to 100 millimeters of mercury. Bicarbonate is 20 to 26. Sorry for typographical error. This is millimoles per liter. So the ideal value is 24 millimoles per liter, and base excess is -3 to +3. There are two terms in your ABG strip that you may see as standard bicarbonate and actual bicarbonate, and you would wonder which bicarbonate should I choose to do my calculations. It is the actual bicarbonate which you should take. The value of actual bicarbonate you should choose. The standard bicarbonate is the content of bicarbonate in arterial blood at 37 degrees centigrade. At PaCO2 of 40 millimeters of mercury at saturation of 100%. This is the ideal condition. This is the standard value. And in ideal situation, both the value, when there is no disease process, both the values should be same. Base excess is the delta base required to normalize bicarbonate 20 to 24 with the PaCO2 of 40 millimeters of mercury. And this value then we use whenever in any situation, if we need to give soda bicarb, this base excess value we use for calculating in a formula, we substitute it. PaO2, have told you that always correlate with FiO2. PaO2 upon FiO2, normal is 400 to 500. But the easy way to remember is in a normal person, in an adult healthy person, say like my PaO2 would be 100. I am breathing a room air of say 0.21, which is 0.20. So my PaO2 FiO2 ratio is 500. So even if you do not remember the number, but if you remember 100 and 0.2, this is how you calculate. And the lower limit is 400. Lesser than 300 is something which starts getting alarming. And then we have to manage ventilatory management and other managements needs to be undertaken. If suppose nowadays in strips or in say case reports, this is how a lot of times the value you may see as say pH oblique PaCO2 oblique PaO2 oblique bicarbonate. Please note that the third value is not bicarbonate, the third value is PaO2. So something like this you may see as 7.4, 40, 100 and 24. So if you see numbers like this, you would, even if it is not mentioned, you should know what it means. So let us see what is the difference between ABG and VBG sample. If your patient is in shock, you cannot get arterial sample. Can we do with a VBG sample also? And what is the information that my VBG sample is given? So if you look at this chart, if you look at this table, you see that it is the It is primarily the PO2 where the maximum difference exists. PO2 of venous blood is very low, as we all know, and accordingly the saturation is also low. Otherwise, more or less, they are similar. pH is slightly low, 7.36 compared to 7.4, and bicarb is high, 24 to slightly high, 24 to 28 millimoles per liter. So, and in case you want your electrolytes, then also you can get by taking a VBG sample. Remember, this VBG also will have to be a hyperonized sample. Quickly we'll go through some terminologies. What is difference between acidemia and acidosis and alkalemia and alkalosis? Acidemia is a term where the blood pH is 7.3, less than 7.35, and it is called alkalemia when it is less than 7.45. So it is the number which is determining when to call it acidemia or alkalemia. Whereas acidosis is the process, the abnormal process which is tending to lower the blood pH, and alkalosis is an abnormal process which is tending to raise the blood pH. Now, what is happening in our body is that pH, it will depend on PaCO2 and our bicarbonate. PaCO2 is regulated by respiratory, by our lungs, and bicarbonate is present in our blood, which is then regulated by kidneys. So these are primarily the buffer systems which are coming into play whenever some compensatory mechanism is occurring. So initial change, whichever occurs because of some primary underlying disease, that is called the primary disorder. And whenever some compensatory mechanism is taking place because of buffering capacity of the body, that is called a secondary response, and it is called as a compensatory disorder. So what is the primary acid-base disorder? When any bicarbonate change is there, it is called metabolic. When any respiratory change is there, because of respiratory change is there, it is because of PaCO2. So remember that whenever PaCO2 is high, at that time your pH would be low. So that is metabolic acidosis, and vice versa. So the easy way to remember is change in PaCO2 and pH are in opposite direction. And whenever your bicarb will fall, your pH will fall, and bicarb will rise, your pH will rise. So both of them move in the same direction. And for ease, for the purpose of remembering it, you can remember the mnemonic ROM. In respiratory disease, it is opposite pH, and in metabolic disease, they move in the same direction, pH, and your bicarb. What is compensation? Compensation I've already talked about. In compensation, look, if suppose your PaCO2 is rising, so pH has decreased because of that. So now what body will try to do is, body will try to bring down this, bring up this pH. So for bringing up this pH, your bicarbonate has to increase. So PaCO2 was high, pH was low, but bicarbonate has to increase in order to bring it towards normal. So PaCO2 and bicarb, both of them are moving in the same direction. So PaCO2 has moved in opposite direction to pH, bicarb has moved in the same direction to PaCO2. This is what is the normal compensation. Whereas in mixed acid-base disorders, PaCO2 and bicarb move in opposite direction. These are some easy ways to remember, which will help you in quickly telling what could be the diagnosis. This is a comprehensive chart where it is showing that in metabolic acidosis, pH falls, bicarb also falls. Your PaCO2 will also fall by virtue of alveolar hyperventilation. In metabolic alkalosis, pH increases, bicarb also increases. In this case, your alveolar hypoventilation occurs. To some extent, this also occurs in order to try to compensate for rise in PaCO2, rise in bicarb. In respiratory acidosis, pH is low because of a high PaCO2. So bicarb rises with it. In alkalosis, respiratory alkalosis, bicarb has to decrease in order to compensate for decrease in PaCO2. So now let us learn what are the various steps. If you follow them stepwise fashion, it is pretty easy to come to diagnosis. First, we will see what is the pH of the patient, then go to PaCO2, then bicarb, and check in case if you find it is respiratory component, then you have to see whether it is acute or chronic, and any of them, whether respiratory or metabolic, whether the compensation is adequate or not. There are various formula, which I'll be telling you subsequently. In case if there is metabolic acidosis, you will have to calculate anion gap and gap or delta gap. Other than that, this is all about acid and base imbalance that we are looking at. Remember, there is also PaO2 to be looked at. Most of the times we are looking in ICUs, we are managing the ventilatory part of the management. So please do not forget to look at the PaO2 and get too distracted by the change in other parameters. I will not be talking in detail about it because it has been dealt in on your oxygen therapy chapter. So, but please remember to correlate it with FiO2. I'm telling you time and again, the most important thing about PaO2 is to remember this. And finally, after making a diagnosis, remember it is always has to be correlated clinically and then treated accordingly. So let us go in stepwise fashion, look for pH, and I'll be giving a case scenario, and subsequently we'll be following up this case scenario at each step. So this is a 60-year-old male who has presented with COPD and with a history of UTI. He presents to us in emergency with, this is the pH of the patient. So pH of the patient is 7.26. So I look at the pH and make the simple diagnosis as acidemia, as it is less than 7.35. So next thing that I look at is what is the primary process, which is respiratory or metabolic. So what do I look at? I look at PaCO2. So now pH is low, PaCO2 is high. Both are in opposite directions. So the component is respiratory. So I make the diagnosis as respiratory acidosis. Now the next thing that I have to look at is whether is it acute or is it chronic. So that is on the basis of some formulas, some calculations that I'll have to do. These are the two formula that you'll have to memorize. That for if there is acute respiratory acidosis, pH change is 0.008 for each mm change in PaCO2. Whereas for respiratory alkalosis or in acute, in chronic, it is much lesser. The pH change is much lesser because it occurs over a longer period of time. It is 0.003 change for each mm change in PaCO2. So let us take this case. If suppose we presume this is acute and we find that the expected pH is 7.05, but my patient's pH is 7.26. So this is definitely not acute. For chronic, when I substitute the values, I get the value of 7.27. So my pH is 7.26, close to 7.27. So this patient has chronic respiratory acidosis. Otherwise, also, if you look at the history, COPD patient would definitely have a component of chronic respiratory acidosis. Let's go to the next step, which is the compensation in this patient. So let's see whether the compensation is adequate or not. So what is there for to check for the adequacy of the composition? For respiratory acidosis, there is 1-4 rule. For respiratory alkalosis, there is 2-4 rule. So for acute respiratory acidosis, the change in PaCO2, that is delta PaCO2, for that you have to multiply with 0.1. In chronic, it is 0.4. For alkalosis, it is 2.5. Whatever delta is there, multiply with 0.2 and 0.25 accordingly. So again, let's proceed with our case. My patient is a case of chronic respiratory acidosis. So in this, so for chronic, I had to substitute the value as 0.4. So the 84 minus 40 into 0.4, the expected compensatory change is 17.76. So 224, this should be the increase. So expected bicarb is 41.6, and my patient's bicarb is 40. So this is more or less well compensated. So my diagnosis now becomes chronic respiratory acidosis with adequate compensation. So stepwise, we have from acidemia, we came to respiratory acidosis, then chronic respiratory acidosis, and then with adequate compensation. Let's take another scenario where suppose you get a patient who has got metabolic acidosis. So there it is a different formula. It is Winter's formula you will have to use. There for Winter's formula, for metabolic acidosis, expected PaCO2, it will be, this is the formula, 1.5 into bicarb plus 8. It can be less than plus minus 2. For metabolic alkalosis, expected PaCO2 would be 0.7 into bicarb plus 21 plus minus 2. So let's see another case where pH is 7.23 and bicarb is 17. So this is definitely metabolic acidosis. So here I would like to see whether my compensation is adequate or not. So I substitute the values, and here I find that the expected PaCO2 is 33.5 and the PaCO2 of my patient is 34. So this is adequately compensated, right? So next, let us look in the same patient. I'll have to calculate the anion gap. So right at the outset, I would like to clarify one thing. Anion gap should not give you the impression that in our body, there are lesser anions compared to that of cations. In our body, there has to be an equilibrium between cation and anion. It is the unmeasured anions that we are talking about, right? So this is the figure that will show you in an extracellular compartment. The main positive cation that is present in our body is sodium. So that is what we will be taking into account. Some of the people also do calculation with taking into account potassium also, which is 3.5 to 5.3. So if you include that, then your anion gap would change accordingly. Most of the calculations are made by using sodium only. And the negative ions which are present are primarily two main ions which are measured. These are the measured ions, is chlorine, chloride, and bicarbonate, 124. So what is anion gap? Anion gap is, these are the unmeasured anions that we are talking about, because these are the ones which we are not measuring regularly. And these are phosphate, sulfate, organic acids, and protein. And protein is a major chunk here. So because of that, actually what you have to do is albumin plays a major role here. So whenever there is hypoalbuminemia, we have to do correction for hypoalbuminemia, where for every 1 gram decrease in serum albumin from 4 gram%, we have to add 2.5 to the measured anion gap. I hope I have made the concept of anion gap clear, because it is only the unmeasured part which is there. The normal is 8 to 12, because this is something that we are not measuring. Now let us go. There could be two scenarios where you can have you can have an acidosis even with a normal anion gap also. What can be the scenario in that situation? Let's see this situation where what has happened is your bicarbonate has decreased. Your chloride has stayed the same. Since bicarbonate has decreased, your anion gap would increase accordingly. So this is a high anion gap metabolic acidosis. Bicarbonate is less, so this is definitely metabolic acidosis. Here also bicarbonate is less, but you can appreciate that your chloride has increased here in comparison to this. So because the chloride has increased, if you subtract this plus this from 136, your anion gap would stay the same. So this is your normal anion gap metabolic acidosis, and this is quite commonly seen. So let us see what are the conditions where these two different kind of situations exist. First, I'll in fact talk about the normal anion gap acidosis. What happens here in diarrhea is that in diarrhea, the patient is losing a lot of bicarbonate, and your chloride is retained. Because of that, you have increased chloride, less bicarb. Because of less bicarb, there is acidosis, but your anion gap does not change. This is a very important condition. Whenever you are taught normal saline in your PG classes, you are taught that normal saline can cause hyperchloremic metabolic acidosis, and that it causes by virtue of this only, because normal chloride concentration of chloride is 145, which is very high. In our body, it is 100 maximum, is 105, 110. So this high chloride, when it is present in the body excretes, in order to maintain the internal milieu of anion, body excretes bicarb. So bicarb gets excreted, high saline, chloride is there in the body. So there is hyperchloremic metabolic acidosis. High anion gap acidosis, ketoacidosis, you people have dealt with in your undergrad days, in your post-graduation also. So you know that you would find high anion gap, and they are the ones who also present with metabolic acidosis. Lactic acidosis, very commonly seen in your shock states, sepsis. That is where also you will find anion gap, and end-stage renal disease. These are the three primary conditions you will be seeing in your day-to-day practice. Please remember that this is something that you will find in these situations. This is a gap or a delta ratio, where the change in anion gap divided by change in bicarbonate is measured, and a certain ratio is seen. It's been found when it is high anion gap metabolic acidosis, it is 1:2, and when it is less than 1, then it is normal anionic gap metabolic acidosis. So whenever, say, this can be used in cases of your diabetic ketoacidosis, initially you would have the value between 1 to 2. When you start resuscitating with fluids, so what happens is your chloride starts getting, when you give fluids, your bicarbonate may still not change, but your chloride keeps on getting replaced. So it gets converted towards your normal anion gap metabolic acidosis. So basically your dehydration gets improved. That's how basically we are making use of this gap ratio. So with this background information in mind, following this all stepwise manners, we have come to read ABG. Let's see how do we correlate them clinically. Remember, I'll quickly go through these slides. Remember that respiratory acidosis would be something to do with respiration, and something to do with respiration could be either because of some problem centrally or some problem in the lungs. So some neurological problem, anything can cause respiratory problem, that can cause increase in PaCO2. Your spinal cord problem can respiratory problem can cause rise in PaCO2. Anything related to lung problem, trauma, lung infection, COPD, anything can cause PaCO2. So you don't have to sort of mug up these conditions. If you think logically, you can always remember what are the various causes and what are the signs and symptoms. Remember, it is rise in PaCO2. Rise in PaCO2, we are dealing in our day-to-day practice what to expect in the rise in PaCO2. It causes obtundation, it causes your sleepiness. Actually, it does not initially, it will cause rise in blood pressure, but later on when it leads to decrease in respiration, causes hypoxia, then hypotension will, then that is the time your vasodilatation will occur and BP would fall, right? So if you remember your physiology well, you would always be able to tell the signs and symptoms. And what to do about them? Primarily, it is the ventilatory part that you'll have to take care of. Respiratory alkalosis, your patient is breathing faster. So again, CNS could be a cause, and a lot of times it can be because of anxiety, panic attacks. Also, you can have increased respiratory stimulation. And the CNS changes that can occur, that those CNS changes are because of decrease in PaCO2 or your cerebral vasoconstriction occurs. So those are the conditions that cause it, right? Here also, you'll have to remember to treat the primary cause. Metabolic acidosis, very commonly seen, shock, hemorrhage, diabetic ketoacidosis, sepsis, lactic acidosis, renal failure. Remember what to expect in them, how to treat. Primary cause needs to be treated, IV fluids need to be given. Remember that bicarb is really not the treatment of choice when you get metabolic acidosis. Less than 7.2 or even less than 7.15, that is the time only when you should be thinking of giving soda bicarb in this. And even bicarb should be less than 8 to 10, then only you should think of giving it. The deficit, this is the formula that we use as 0.3 into weight into base deficit, which your ABG gives. Half of the above calculated doses given. Regarding metabolic alkalosis, pretty commonly seen in ICUs because they are the patient, and more so in your surgical subset of patients. They are the patients where you will have a lot of NG aspirates, you'll have various kinds of fistulas, those patients presenting with prolonged vomiting, you have excessive use of diuretics, all of them will present to you with metabolic alkalosis. And here you can have, because of metabolic alkalosis, it is associated with hypocalcemia. So the symptoms of tetany and all the symptoms of hypocalcemia will be seen in the patient. So you need to treat them accordingly. Remember, in these patients, acetazolamide is also given because this is the one which retains chloride, excretes bicarb. So that's how your ABG gets, your pH comes to normal. So let's now move on to the ABG case scenarios. This is the first case where a 50-year-old female presents to you in emergency with history of acute diarrhea for 2 days. She is dehydrated and she has tachycardia with BP of 160, respiratory rate of 26, and is on room air. So let's see. The first thing that we will see is what is her ABG, what is her pH. Her pH is 7.31. Her pH is 7.31. So it is acidemia. So next step that we have to look at is what is his bicarbonate level. Bicarbonate, let me just locate the cursor. Just a moment. No, cursor. There is cursor. Okay, yeah. Yeah, so thank you. pH is 7.31. So this is acidemia. So the first thing that we have observed, the next thing that we have to look at is what is the PaCO2 of my patient. PaCO2 is 33 and bicarb is 16. So my pH is low. My bicarb is also low. So this shows that my patient is having primary metabolic acidosis. Okay, so when my patient has primary metabolic acidosis, I have to look at the fact whether my compensation is adequate or not. So for that, I'll be using Winter's formula. So when I substitute my values in Winter's formula, I find that by substituting the values in Winter's formula, I get 32 millimeters of mercury of PaCO2 is expected if the compensation is adequate. And my patient's value is 33 millimeters of mercury. So that is how I say that the patient is well compensated. Since this is a metabolic acidosis, I'll have to calculate the anion gap. So let me see what are the various anions that my patient has. Patient has a sodium of 134, potassium of 3, and chloride of 106. When I substitute the values, I find that the anion gap is normal. Anion gap is 12. But there's one more observation that I have made. The potassium is low. It is 3 millimoles per liter. So what are the findings of my patient? The findings is normal anion gap metabolic acidosis with adequate compensation with hypokalemia. This is my complete diagnosis. And what do I need to do for this patient? This patient was having diarrhea, so I'll need to give adequate fluids. Along with it, I'll also need to replace his potassium. This is a 32-year-old male who is admitted with respiratory symptoms of cough with expectoration, fever and breathlessness. His oxygen is being given to him at FiO2 of 0.5 with venturi mask. He's showing an PaO2 of 60 millimeters of mercury. Let's first analyze ABG. The PaO2, the pH is low. So my patient is having acidemia. Let me look at the PaCO2. PaCO2 is 55. So pH is low. The PaCO2 is 55. Both of them are in opposite direction. Both of them are in opposite direction. So this is definitely a respiratory problem, right? Now let me see whether this is a whether this respiratory problem is acute or this respiratory problem is chronic. So what do I do? Let us first check. For the acute change. For acute change, I'll be using the formula as 0.008. I find by calculation, I find that the expected pH is 7.28 and my patient's pH is 7.29. So this is acute respiratory acidosis. Let's see what about the metabolic compensation. In metabolic compensation, here since this is acute respiratory respiratory acidosis, metabolic compensation 0.1 needs to be multiplied to the delta PaCO2. So 1.5 millimoles per liter change is expected. I add to the 24 normal value of bicarb. So this is 25.5 and patient's bicarb is 26. So this is again well compensated. So my diagnosis is acute respiratory acidosis with adequate compensation and my PaO2 is decreased. It is, I'm giving 0.5 FiO2, whereas PaO2 is only 60. So which is 60 divided by 0.5. It is not even 200 less. It is approximately 150. So something really aggressively needs to be done as far as this ventilatory management is concerned. Another patient presents in emergency with shallow breathing. This patient is on anxiolytics, antidepressants, gives history of panic attacks. This is what happens. The pH is 7.48. and PaCO2 is 28. So let's see, both of them are in opposite direction. pH is high. So this is primary respiratory alkalosis. Let me check whether this is acute or chronic. So for that, in alkalosis process, for each change in PaCO2, I'll have to multiply it with 0.008. So this is what I get. The change after adding it to this, I find that the expected change is 7.29 and the patient's value is 7.49 and expected pH is okay. Expected pH is 7.49 and patient's pH is 7.48. There is typographical error here, please. Expected pH is 7.49 and patient's pH is 7.48. So this is more or less what is expected. So my diagnosis is acute respiratory alkalosis. So, and this patient was basically very anxious, was hyperventilating. So that was the cause. So one has to take care of, maybe give anxiolytics, reassure the patient. Sometimes in panic attacks, these are the things that need to be undertaken. Patient needs to be admitted for some time and treatments needs to be undertaken. In this patient, the pH is 7.37. PaCO2 is 26 and bicarb is also low. Let's see what happens. Both here, here primarily the bicarb is like really low. So the primary composite, component would be primary metabolic acidosis. So as bicarb and your pH is less than 7.4. So since they are in the same direction, my main component is primary metabolic acidosis. Let's go ahead with the compensation by checking through Winter's formula. I find that the change in, this is the expected changes, 32 millimeters. I should expect PaCO2 to be 32 millimeters of mercury, whereas my patient's PaCO2 is 26. So my patient also has associated alkalosis. So only on the basis of calculation, we can tell whether my patient is associated alkalosis or not. So this is, my patient has primary metabolic acidosis and associated respiratory alkalosis. This is another patient. This patient is acidemia with of a pH of 7.2 and bicarb of 8. By using Winter's formula, I find expected PaCO2 to be 35, whereas patient's PaCO2 is 48. So my patient has also associated respiratory acidosis. All these are mixed disorders. Here, when I calculate the anion gap, I find that the anion gap to be high anion gap metabolic acidosis. The gap is, I find to be 1. So it is a high anion gap metabolic acidosis, which is a pure type of high anion gap metabolic acidosis, and also with respiratory acidosis. Let's come to another case. This patient has a pH of 7.4 and a PaCO2 of 60. Patient has primarily respiratory acidosis. Let's check quickly whether this is acute or chronic. We find by calculation that the expected pH is 7.24 according to acute calculation, and the patient's pH is also same. So this is acute respiratory acidosis. Let's look at the metabolic compensation. The metabolic compensation is not what I would expect. The expected bicarb is 26, whereas patient's is lesser than that. So patient has associated metabolic acidosis. So this is acute respiratory acidosis with metabolic acidosis component, and my patient also has hypoxia. So patient has mixed disorder with and hypoxia. These are the patients who could, these are the patients who have primarily some, say, pneumonia along with associated shock or sepsis. So because of that, you can have this kind of a condition. This patient of IDDM who has skipped his insulin, you know the history, from this history what to expect. Your pH is low. So here there is acidemia. Your bicarb is low. So you have metabolic acidosis. Let's check it, the compensation. Patient's pH is 34, whereas according to compensation, it is lower. So patient also has associated respiratory acidosis. So my patient is not breathing well, also has got respiratory distress. Let's check anion gap. Anion gap shows a high anion gap, and your gap or delta gap shows 1.4, which is a pure type of high anion gap metabolic acidosis. So this is anyhow, I would expect ketoacidosis in this patient. Manage my patient's accordingly with fluids, insulin, and then keep managing, doing my ABGs. No bicarb is required in this. If you manage the primary problem, the condition gets taken care of. Thank you so much for the patient listening.
Thank you. Thank you, ma'am. Ma'am, there are 2 questions for you.
Okay.
Ma'am, first question is, in the first case scenario of COPD, how is it compensated when pH is less than 7.26?
In this case, actually, since this is a chronic patient, so if we do the calculations, it is compensated, but gradually, you know, what happens is the bicarbonate keeps on increasing, and then it will turn towards, this is the initial scenario when we were doing it. So this is a chronic patient, they learn to live much of, sort of pH, and that's how say that, you know, patient is living with this kind of a pH. That's how because this was a chronic patient, had this been in an acute situation, then it would have not been in a compensated situation.
And ma'am, the second question is, please explain strong iron difference.
Strong iron difference is actually, there are various terminologies used for this. The strong iron difference, we use the anion gap terminology, the strong iron difference terminology, where you measure these ions, sodium, potassium, and then these are basically the 2 different terminologies which we are talking about. I have talked about primarily the anion gap difference. You can, if you want to use the strong iron terminology, then you can follow that system itself, but this is what is more routinely used. So that's why I have talked about the anion gap difference.
Thank you, ma'am. Asha, ma'am. Would you like to say?
So, yes, definitely. I would like to thank Dr. Nija, because this is a rather...
You are not audible, ma'am.
You're muted.
I'm not audible. Okay. I'm unmuted.
No, I'm not audible
yet.
Not audible yet, ma'am.
You're audible, ma'am.
Audible, ma'am.
I can hear.
Am I audible now?
Yes, ma'am.
Yeah, because I'm unmuted. So yes, I would like to thank Dr. Nija, because the topic in itself is huge. It is difficult always to comprehend, and there are so many concepts attached to this single interpretation of an ABG. So I think she did a great justice to that for these many reasons. So thank you, Dr. Nija, and I hope the students, they should have benefited. I am quite sure about that. Thank you so much. Thank you.
Thank you, Asha ma'am. Thank you, Nija ma'am. It was a wonderful presentation. Now, next we have a short case presentation. The external examiner for the short case is on congenital cataract, and the external examiner is Dr. Jyotsna Agarwal, and the moderator is Dr. Ankita. She is senior resident from our hospital. And Jyotsna madam, she is professor and in charge in pain clinic, Hamdard Institute of Medical Science and Research Institute. And ma'am's